Welcome to the NWAETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to our speaker for the talk today.
So I was just in from IAS, and there was a lot to talk about there. The START study and the Temprano study were published, and there was a lot of buzz about those and how the WHO was going to respond to those. So I thought I'd review those papers and then some things that were published recently looking at novel strategies for controlling HIV, and then we'll finish up with a couple of slides on some new agents and data that was presented at IAS on these new drugs. So the START study, this is published. It's not yet in print, but it is available e-publication just a couple of days ago. This study is this large randomized study to look at whether or not starting ART immediately when T cells are greater than 500 or waiting until T cells are less than 350 leads to better outcomes. So this was a huge study, 215 sites in 35 countries that opened enrollment in 2011. 4,685 men and women, median age of 36, and everyone had a T cell count greater than 500. There were more males than females, 63 to 27, and the median CD4 count at entry into the study was 651 with a viral load that was a little low at almost 13,000 copies, and the median follow-up was just shy of 3 years. This study did include patients who were in low, middle, and high income countries, so it had a pretty good representation no matter where you are in the world. And its outcome was a combination of serious AIDS events, serious non-AIDS events, and death. So the DSMB analyzed the data in March of this year and stopped the study because of significant differences between the groups. So the early treatment group, there were 42 events, and the deferred group, there were 96 events. And on the graph to the right, the top panel is the time to a first primary event, and you can see it happened much more frequently in the deferred group, the group that was waiting until their T cells were less than 350 compared to the immediate group. So that represented a 57% reduction in the primary endpoint in the early treated group, and this benefit was regardless of their age, sex, race, their country, CD4 count, smoking status, or Framingham risk score. If you look at serious AIDS events in panel B and then non-AIDS events in this panel, the surprise was that there were more AIDS-related events that happened in the deferred group, even though people had relatively high CD4 counts. So when you break the study down in this table, this is the immediate group, this is the deferred group. The composite endpoint was much lower in the immediate group compared to the deferred group, and that was highly statistically significant. And when you look at the components of that endpoint, it really was the serious AIDS events that drove the difference between the two groups. And when you drill down even farther, most of that was tuberculosis, Kaposi sarcoma, and lymphoma, those AIDS-related diagnoses that happened more frequently in the group that deferred therapy, even though they had relatively robust CD4 counts throughout this study. So kind of definitive proof that regardless of your CD4 count, you are going to see a real benefit from initiating antiretroviral therapy. So the companion paper that came out in the same issue of the New England Journal was the Temprano study. This is a little bit different. This was an unblinded, large randomized multi-center controlled trial that had a 2x2 factorial design. It was conducted only in the Ivory Coast and included over 2,000 men and women greater than 18 years of age who had CD4 counts less than 800 and who met no criteria for starting ART. So their CD4 counts were less than 800, but they couldn't have been less than 350. And they were randomized to either deferred ART therapy, deferred until they met criteria, WHO criteria, 2013 criteria for starting treatment, or they were on deferred therapy plus INH prophylaxis treatment, or they got treated right out of the gate with ART, or they got ART plus INH. And the primary endpoint in this study was a composite of an AIDS illness, a non-AIDS cancer, a non-AIDS invasive bacterial infection, or death in the 30-month follow-up. So median CD4 counts in this group was a little bit lower, 460, but 40% of people did have CD4 counts that were greater than 500 on study entry. So the results, TB and invasive bacterial disease accounted for most of the primary endpoints, so 42 and 27% respectively. So the graphs on the right show all patients meeting the primary outcome, and the top blue line is those who deferred ART therapy, so this is all patients. And then if you divided them into those with CD4 counts greater than 500 or less than 500, there still was a notable difference in the group whose T cells were greater than 500 and who started therapy early. The deferred group had more people meeting that endpoint. The hazard ratios are over here on the table. For all patients were 0.56, starting therapy early versus delaying. And for the group whose T cells were over 500, it was the same hazard ratio of 0.56. And despite starting therapy early, there were no difference in grade 3-4 adverse events in the groups that started ART sooner than the deferred group. So again, kind of confirming what was seen in the START study, that initiating ART at any CD4 count leads to better outcome. Okay, so there were some other studies that were recently published that I thought were worthy of review, and there are 3 of them that I wanted to bring to everybody's attention. The first is the SALT study. So this was a randomized open-label study conducted in Spain of almost 300 patients. All patients who entered this study were already undetectable on antiretroviral therapy for at least 6 months, and they were randomized to boosted atazanavir plus lamivudine alone, or boosted atazanavir plus 2 NRTIs, the standard therapy. And the primary endpoint was less than 50 at 1 year. And dual therapy, the punchline, was not inferior to triple therapy regardless of the analysis, so using a LOVR analysis or a snapshot analysis, and whether it was per protocol or intention to treat. The dual therapy with a boosted PI plus 3TC did as well as that standard triple therapy, and there were fewer patients in the dual therapy arm that discontinued their treatment. So a surprise that just a boosted PI plus lamivudine was as good as standard therapy. The GARDL study, so this is a little bit different and using a different PI, using boosted lopinavir plus lamivudine versus boosted lopinavir plus 2 nukes. And this was a bigger study, almost or a little over 400 patients in the Americas, Spain, and the United States. Patients here were ARV naive, so they were starting on therapy with detectable virus. Their median CD4 counts were 320. Pretty good viral loads, was almost a half the patients having viral loads greater than 100,000 copies. And they were randomized again to Kaletra plus 3TC or Kaletra plus 2 nukes. And the primary endpoint again was CD4 viral load less than 50 copies a year into treatment. And here, dual therapy, again, did just as well as standard triple therapy. So less than 50 for all patients was higher with dual therapy, and for the subgroup who had viral loads greater than 100,000, they did actually better than the triple therapy group. That was largely due to discontinuations due to toxicity for the people who were getting 3 drugs. And the graphs on the right, the top is showing all patients and the meeting undetectable levels over time. And the graph at the bottom is those individuals whose viral loads were greater than 100,000. And again, there were more adverse events in the groups that had triple therapy. And the final study was just like the GARDL study I just presented, except this was a little smaller, and patients were already undetectable for at least 6 months on Kaletra plus 2 nukes, and then they were switched to either mono Kaletra plus lamivudine therapy or just continuing on their original therapy. Same endpoint, less than 50 copies at 48 weeks. And once again, those treated with dual therapy did just as well as those treated with triple therapy. So I think these studies are really relevant for the developing world where cost is such an issue. And if we can simplify regimens down to 2 drugs rather than 3 drugs, it would be a significant savings for many of these patients. And a boosted protease inhibitor plus lamivudine alone looks like it's a highly effective therapy. So then I wanted to present just a few studies that were presented at IAS. It wasn't rich with ARV studies, but a few that were worth mention. The first was presented by Tony Mills from Southern California. He was looking at patients who had switched from tenofovir to TAF-based regimens, and the data is from suppressed patients at 48 weeks. So this is a big study, or a big observational cohort of over 1,200 patients, so maybe the biggest collection of switch patients that's been published. They had all been undetectable, so viral loads less than 50 for 96 weeks, and had been on either Stribild or Atripla or boosted atazanavir plus Truvada, and they switched to Stribild with TAF in it instead of Stribild with tenofovir in it. And their viral loads were less than 50 at 48 weeks, and it was a little bit better. In fact, it did meet criteria for superiority in terms of viral efficacy for TAF versus tenofovir. This was likely due to better tolerability of TAF and people not bailing off their regimen. And they had slightly increased bone mineral density and less renal effects, although they didn't really go into that in the TAF-treated patients. And the second presentation from Dr. Gupta, I think out of Minnesota, he was looking at individuals who already had renal impairment, were on a tenofovir-containing regimen, and they were switched over to TAF. This was a single-arm, open-label study, and they demonstrated increased renal and bone safety at 48 weeks. There was no change in GFR over switching people onto TAF, but there was reduced retinal binding protein, beta-2 microglobulin, and protein excretion in all the patients who went over to TAF, and improved bone mineral density and slightly worse lipid profiles. And then the last paper on new ARVs was presented on doravirine. This is a short follow-up study, the efficacy and safety of doravirine plus Truvada versus efavirenz plus Truvada in AR-naive patients. This was only data from 24 weeks. One of the advantages of doravirine are that it has a unique resistance profile, so that it will be active against viruses that are resistant to other non-nukes. And it is metabolized by CYP3A4, but it does not induce or inhibit the enzyme. So less to worry about in terms of drug interactions. 216 patients, and there was only 24-week analysis, and I was writing fast, so I hope I got the numbers here. But for all patients, less than 200 and less than 40, 90% and 73% not different from the patients who were on efavirenz. And when you divided it out by viral loads greater than or less than 100,000, again, not different from efavirenz really, but not very many people were undetectable. Remember, this was only at 24 weeks, and all patients were kind of on the road to undetectable, but hadn't gotten there yet. I think probably the most valid comparison is just comparing doravirine over to efavirenz, and it as well didn't have a lot of people that were less than 40 at 24 weeks in that group that had viral loads over 100,000 at baseline. Many fewer side effects in the groups that were on doravirine, and they were almost all CNS side effects that where the difference lied. So those are the new drugs that were presented. There were a few other presentations there that I didn't bring forward, but I thought those were the most notable ones.